and welcome to the Home of Medicine podcast with me, Dr. Amy Burbridge. Season 2 is underway, and I am joined today by
Dr. Steven Laird.
Today, I am going to be asking Steve a few questions. Now, Steve is a microbiologist and a physician, and I'm going to be discussing 2 cases with him that I saw as an acute physician, but I needed some help. I was stuck, and I didn't quite know where to go next. So, Steve, it was a Saturday morning and I was on call.
It always is.
Sorry?
It always is.
It's always a Saturday morning, isn't it? I know, that's true. And I was on admissions and it was extraordinarily busy and huge numbers of patients to see. And the second gentleman I saw was 40 years old and he looked really, really well. So I was like, why is he here? Why is he here in hospital? He's absolutely nothing wrong with him. He's chatting away, he's tapping on his phone, he's absolutely fine. And I went up to have a chat with him and I said, how are things? What's brought you into hospital today? And he said, well, 2 weeks ago, I was in ITU, the intensive care unit in London. And I was like, okay, didn't expect that. He's been in hospital for 2 weeks in London where he'd been diagnosed with a viral infection that was so bad that needed an ITU admission because he developed sepsis. So he was in ITU, although he didn't need intubation and ventilation. He needed inotropic support for his hypotension and his tachycardia. There had been no formal diagnosis given to him apart from viral infection leading to sepsis. Now, interestingly, this gentleman worked on the air conditioning ducts in hospitals. And his job was going around the hospitals, and he sort of described it as he hoovered and cleaned out the air conditioning ducts, and he'd been doing this for 3 years. Mm-hmm. Now, he was based in the UK, but originally came from Romania, where he visited recently and had last been there a couple of months before his recent admission to ITU. And the reason he'd come back to hospital was after his discharge, he just didn't feel right. And he just said, I just don't feel right. There's something not right. And he called the ambulance crew a couple of times. He'd seen the GP and they said, continue with your pain relief and, resting. You need to rest. He was very active. He wanted to be busy all the time. But he was finding that actually he was very short of breath and had quite significant chest pain, central chest pain. And I was like, okay, so he's recent hospital stay, he's short of breath and he's got chest pain. This must be a PE. The acute physician in me thought that. His legs, there was no evidence of calf swelling. There was no tenderness that would suggest a DVT. And actually, on examination, when I looked at him from the end of the bed, he looked, as I say, incredibly well. His pulse was 80 beats per minute and regular. His blood pressure was 130/96, so a slightly high diastolic figure. And he did say occasionally he does have a little bit of high blood pressure. His heart rate was 120. And what was interesting is his heart rate kept going up and going back down. So during the morning when he was with us, his heart rate would go up to 150, 160. And he would say, I've got the palpitations again. My heart's feeling really tight. My chest's tight. And I was like, okay, let's put you on a monitor. Let's have a look at your heart rate. Let's really monitor this. And when this happened, it became quite sweaty. His temperature was 38.6. So obviously he was still feverish. His chest was clear on auscultation. His heart sounds were muffled, couldn't really hear them very well, but his breathing was quite noisy. So although his chest was clear, he did have a little bit of an increased respiratory rate and he was just struggling to breathe a little bit. Nothing else of note, and the abdomen was nice and soft and non-tender. There was no bruises, there was no rashes. There were signs of previous cannulation and bloods, where bloods had been taken when he'd been in the intensive care unit, but again, nothing else of note. So he had a letter from his recent hospital stay that detailed some investigations. So his COVID serology was negative. He hadn't had the flu. They tested for TB, it was negative. Hepatitis was negative. HIV was negative. I was stumped because he was still feverish. He was tachycardic, so we did an ECG. And the ECG showed some very subtle ST elevation throughout.
Okay.
So I was like, okay, so he's got subtle ST elevation throughout of the ECG, a little bit of chest pain.
And fever.
And a fever.
So you're worried about pericarditis?
Yes.
Or a myocarditis?
So this is where I started to think about what do I need to be doing? Okay, so you're right, fever, chest pain, some ST changes, it's not going to be an MI. And his troponin had been done and it was negative, it didn't suggest anything. So at this point...
That's quite useful, isn't it? Because then we know that it's not myocardial damage. So a significant myocarditis from a viral infection, flu causes really bad myocarditis, sometimes in young people, does lead to myocardial damage.
And a raised troponin. Yeah, so absolutely. So his troponin was negative. His white cell count was 13.
Okay.
His neutrophil count was normal at 6. His lymphocyte count was very high at 4.61. Okay, so we'd expect upper limit is around 2, is that right?
Yeah.
And then his CRP, a C-reactive protein of 53, when obviously normal is less than 3. So I didn't know what to do. So I did a CTPA because I was like, he must have a PE because of this chest pain, this tachycardia. And the CTPA showed a large 36 millimeter pericardial effusion surrounding the whole of his heart.
And that's classic with that constant throughout all leads, mild ST elevation.
Okay, so what would you do? So I did speak to cardiology.
Yeah, absolutely.
So, but from a microbiology infection point of view, what could I do?
So this could all be reactive, or it could be a direct consequence of more than likely one of the viral infections, one of the enteroviruses, one of the flu. You might have had flu previously. It could even be something as simple as RSV leading into a pericarditis.
And that's respiratory syncytial virus.
Yes.
Okay.
Thank you. And the season that we've got as well, coming into flu season, and I think that's where we kind of have to think. We have to think at the top of our heads: is this flu and a consequence of that? So do we give him some oseltamivir? Well, we might do, but is that going to make a difference? No, the difference here is going to be making sure that we don't compromise the heart, get that cardiology involvement. Does this need a centesis? Do we need to do a pericardial centesis and drain that fluid off if it's causing restrictive compromise? And by the look of it, he wasn't, but there was definitely something going on. So we've got a little bit of time, so we can do some investigations. Now, this guy works in where I thought you were going to go down the hall. We've forgotten what he does for an occupation. He messes around with air conditioning units. So the things that we think about air conditioning units classically would be things like Legionella.
Okay.
Yeah. And we would have done a Legionella. Hopefully, they'd taken that into account in whichever hospital in London he'd been to, and they'd hopefully have done a Legionella urine antigen. So we would at least do that. He might have had Legionella, and this might be a consequence of it, a very unusual one. In most hospitals, we will give, as a community-acquired pneumonia empirical therapy, a streptococcal and a Haemophilus cover, which is usually a co-amoxiclav, and we will give an atypical intracellular cover, intracellular organism cover, which is your clarithromycin or your levofloxacin, which usually would be there to tackle your mycoplasmas, which can cause pericarditis, and your Legionella. So you might actually just want to give this guy some empirical pneumonia treatment, thinking that this is how this has all begun, and now we've got a pericarditis as a reactive pericarditis, whilst we're figuring everything else out. He's not septic, but I don't think that would be unreasonable to go down that route. However, you've got a big lymphocyte count, haven't you? So we're kind of tending towards a viral thing. So we can have a look to see if you could do your serology for your CMVs and your EBVs. We've got a big lymphocyte count there. Has he reactivated because he's been sick whilst he's been in hospital? Is this an unusual sequelae of infective mononucleosis? Be very unusual, but still, we haven't got anything to work on here. We would do a PCR throat swab for all of your respiratory viruses. So your metapneumoviruses, your parainfluenzas, you get all of those on there. Adenovirus would be something to consider. And then your enteroviruses, which dominantly you would see in your stools rather than in the respiratory tract. But you can see them on that nice PCR test that we can do as well. So, and then of course you're doing your flu A, your flu B, and your RSV. You get them as you come through the front door in this hospital, and other hospitals around Europe probably will do the same in this season. So that's where you would start whilst giving that cover, and definitely getting those other tests in that take a little bit longer, like your urine antigen for Legionella.
Okay, so thank you, that's really helpful, because I was I was okay with the cardiology side of things. So I was happy to speak to cardiology. We did a bedside echo, and at the bedside echo, the fluid is a lot bigger than it identified itself on the CTP, and it was at 8 millimeters. So it was huge. And what was really interesting is over the course of a couple of hours, which we got cardiology involved and we were there with him, the patient deteriorated. Not so he was he was still chatting. He was, still really lively and chatting to his family, was having jokes with everybody else in the ward. And that can sometimes really bias your decision making, because you're like, there's absolutely nothing wrong with him. Look at him, he's sitting and chatting. But young people, he was only 40, are very, very effective at being very well until they're not very well.
Sure. And when they're not very well, it's hard to bring them back, just like children.
Exactly. And, he dipped very rapidly that afternoon, where he developed cardiac tamponade.
Right.
And we had the cardiologist on the ward. We were scanning at the time. He became very unwell. He had all the signs suggestive of tamponade. He had very dilated vessels. He became very hypotensive. He actually became bradycardic. It was like cardiogenic shock. And they took him to the cath lab straight away in the hospital, and they did emergency pericardiocentesis, where they drained 700 mils of fluid.
Okay.
Which was a huge amount. I mean, I didn't even think that amount could be around the heart. I was shocked.
We see even more in, so if you have an acute pericarditis, whether it be from infection, or sometimes a bit of trauma, or chronic pericarditis, where they develop fluid and the heart it manages to sort itself out a little bit. It doesn't become restrictive. You see that with things like tuberculosis, and the fluid amount that comes off those pericardial centesis are huge litres of litres. They're massive amounts. But the other thing we would offer as an advisory whilst talking to you would be to think about the non-infective elements of this as well.
Okay.
So this guy is really well, but he's got fever, or he had fever, and he was put into hospital, and he's got better, but actually now he's something's still happening. So yes, it might have all been an acute infection leading to a pericardial inflammation, or this might be lymphoma. It might be you're an ex-rheumatologist, that sometimes you have rheumatoid deposits within the pericardium as well, leading to a chronic inflammation. These are the other things that will give you fever as well. So lymphoma, fever, these are the things that we have to think about. Tuberculosis in certain countries, when you've got these big collections, that's the classic one that we would be thinking of. That wouldn't have been treated, but it shouldn't have decompensated him in this manner this quickly.
It was very rapid.
Yeah.
I mean, he's the fluid was sent off for analysis, and no organisms were seen. However, he had a large amount of antibiotics before coming into hospital, so that could have potentially inhibited the growth of any bacterium. Secondly, the fluid showed a glucose of 2.3.
Right.
So that's pretty low. I actually aren't very good at interpreting glucose levels in pericardial fluid, but I know that that's low, and that can often be associated with bacterial infections, isn't it, and TB?
Sure.
So, which interestingly were both negative.
Yeah, and this all sounds viral anyway. So of course we don't culture up viruses in many labs in the United Kingdom. It's all done because they're difficult to culture.
Right.
You need the viruses usually require intercellular mechanisms from mammals of some variety. So, and different viruses need different equipment. So we don't culture them up. Plus, we've got really good molecular tests and serology tests to be able to say, yes, this is here. We've amplified this RNA or this DNA, and it's present.
Okay. So the good news is he responded incredibly well to the pericardiocentesis and went home the next day.
Oh, good.
Yeah. So, I mean, incredible. And so far, he hasn't come back into hospital. He's had a very good recovery. He wasn't started on antibiotics, interestingly. Again, there's debate, isn't there, about whether we should have done that or not.
I think you can flip a coin on that one.
Quite.
You've got enough to say that this is probably some reactive pericardial effusion.
Absolutely. And he went home with some pain relief,
Right.
just if there was any pain, and for follow-up in the couple of months.
There we go.
So it's really nice results too, because when I saw him, he looked so ill. And when I came back in the next day, and it was absolutely fine. I was like, this is amazing. This is like medicine at its best. When somebody's really sick, you've got an intervention and then within 24 hours they can go home. I mean, it really was incredible. Good teamwork as well.
Yeah, and I think that's the key of this whole story, isn't it? That you needed to get the right people at the right place at the right time, and then they had to be aware, even if this patient was sitting there talking to his family, they had to be aware that this has a potential of becoming a devastating syndrome.
Absolutely, yeah. And often when you've got lots of very, very well people, because we are seeing a huge number of people at the moment, I'm sure everybody is, who are often quite well. Sometimes we have to remember that some of these people can be very unwell, and it's about flipping our thinking as well, and really, looking at the patient and taking a history, because actually when you listen to him, he was saying he felt unwell, he didn't feel right, so it didn't correlate with the fact that he was sitting there chatting away. But when you chatted to him, he was like, I really don't, something's not right. And I was like, okay, he followed his gut instinct and he was right. Something wasn't right. So very quick question again, and another patient I saw the same day.
Oh.
This was a very busy day. It was one of those Saturdays where everybody's really poorly, but it was a 50-year-old lady who had noted to have a very large right-sided pleural effusion and a fever. So what I want you to talk to me about is when you've got a pleural effusion, a large right-sided pleural effusion and a fever, what investigations do we need to do?
Okay, so first of all, we need to know why that pleural effusion is there. Is this a reactive parapneumonic effusion? Is this cancer? Is this cancer? And now, unfortunately, some of the respiratory bacteria have kind of translocated into the effusion. What I would say is it's the basics of any kind of source controllers. If you think that is the source of the fever, potentially leading to sepsis, then it needs to be sorted, because you are never going to get the right amount of antibiotic into a large pleural effusion or a large abscess without draining it. You really do need to go back to source control. So we would be on the end of the phone saying, what's causing this? Why is the patient stable? Are we able to get a drain into it and draining it out? Now, if she's got massive ascites and then this is as reactive, and now she's got a pleural effusion on the right-hand side, then you're not going to be able to get rid of that by draining the ascites. You're going to have all kinds of problems. So that's why you need to know what the etiology is. Otherwise, it's either you're going to scan it to make sure it's not loculated in a complex effusion, because there's no point in trying to stick a drain into something which has got multiple septi. You're only going to get a little bit of it out, and that's not going to be good for the patient. So you might want to scan it first, or do an ultrasound whilst you're doing the drain, and then you're going to take that fluid out and send it to microbiology and cytology. So a lot of people will have their cancer heads on, and they'll be thinking, is this cancer? Is this cancer? Is it cancer? And send all of the stuff to cytology and maybe even put a little bit of it through a blood gas machine. I don't think you're allowed to do that these days.
No.
I think they block them. I think that
Absolutely not.
I think that blocks them.
I used to do that years ago, though.
We all used to do it,
Yeah.
didn't we? And I think it all. We used to block the machines up, because especially if they're really, really sticky ones. So yeah, you need to get a lactate. That's the first initial test that you can do. Even if you're not going to drain it, at least do a pleural tap and make sure that this is not an empyema. If you're sticking something in there and you've got white stuff coming out instead of that nice transudate strawy colour stuff, then you know that this really needs a cardiothoracic surgeon to put a big pin into it. Then you can send off the test. You can put it into blood culture bottles. We can try and culture it up and look for bacterial infections. If you're thinking about viral infections, then you can send some to virology, and they can start looking at whether or not we've got tests which are compatible for effusion fluids to be able to test serology, etc., etc. But for me, as a microbiologist who dominantly deals with bacteria, I'd want at least some sample, because it's a big effusion, in some universal containers, and some samples in some blood culture bottles, so we can start doing our little bits and bobs in the lab.
And what sort of bacterium could cause a large unilateral pleural effusion?
So we see it commonly with pneumococcal.
Pneumococcal.
Yeah, so streptococci are a nightmare. So Streptococcus pneumoniae, also known as pneumococcal bacteria, they're the ones that if you have it in meningitis, for example, you are likely or more likely than meningococcal to get those abscess formations in the brain. And it's the same in the chest. You get usually a very, very significant pneumonia, then a reactive parapneumonic effusion. Can look like it's only unilateral, but usually you'd have an element of a bit on the other side as well. And then they can septate and start to abscess out and cause an empyema. And that's when it gets difficult. And that's what, so yeah, pneumococcal, Haemophilus, these, anything can really do it. What we would be concerned about, I guess, is if we found something like a Staph aureus in a blood culture, because we're thinking, where's this disseminated from? And have we got septic emboli throughout the parenchyma of the chest, of the lungs? And is this reactive because we've got septic emboli throughout the lungs, which will then kind of necrose? But the common one would be streptococci.
Okay, what about aspergillus?
What about aspergillus?
So aspergilloma and aspergillus, is that something that can cause a unilateral pleural effusion?
Uncommon.
Okay.
So you have different types of syndromes for aspergillus, and yes, you can have an aspergilloma, which has usually got a stalk, usually inside an old cavity, which is commonly from TB, etc. Or you have invasive aspergillosis, which is causing usually an acute infection in immunocompromised people. Or you have that chronic aspergillosis as well, which is there and flares up and flares down. But to have a reactive unilateral effusion would be unusual.
Okay, is that with all funguses?
By itself. Yeah, because you think about how they come into the lung, they would usually disseminate through both the bronchi. You could see that with bacteria as well, but it's always a bit weird, isn't it, how we usually see lobar pneumonias with bacteria. But with those big amounts of spores, they will usually cause disease. This kind of bud and tree thing that people always talk about, which is non-specific, with the halo signs usually in the chest. So yeah, it's unusual for fungus to cause parapneumonic effusions.
Any parasitic infections?
Oh, what with causing
pleural effusions?
Causing pleural effusions. Oh, let me have a think. So I mean, you do get disseminated. I mean, you get lots of eosinophilic pneumonitis through disseminated helminths like strongyloides, even Ascaris lubricoides. Getting up the big Ascaris lubricoides. You're looking at me like
I'm like
what is
I can't even say that.
This is the big nematode that you see in that blocks up bowels.
Okay.
Yeah, but it can disseminate up and through the chest as well. But strongyloides, it usually causes a reactive pneumonitis. So I guess therefore it probably could cause a pleural effusion.
Okay.
Just not, again, something commonly that we'd see.
Okay.
And I wouldn't send you down that route.
No. So what sort of risk factors would somebody presented with if you were thinking strongyloides? Is there a recent travel, recent sexual history that you'd be going, oh, this could be strongyloides?
Yeah, it's all about travel, hygiene, and then there's a number of ways in which strongyloides can present. But usually when people are getting investigated for it, it's either that they've got a secondary bacterial infection, it's usually associated with gram-negative sepsis, or they will have just an unusual eosinophilia.
Okay, and then so it's the eosinophil count that's key.
It's the eosinophil count that's usually key. Doesn't always have to be in hyperacute infections, for example. It might not be there at all. But people, if they're very unwell with strongyloides, will have some form of cough, shortness of breath. So it'll be affecting the chest, having that Lothus syndrome, or you will have maybe cramps and abdominal pains, where again it's disseminating through. So strongyloides as well is an unusual helminth because it can auto-infect yourself. So it can be present in you for years and years and years.
Right. Okay.
How did we get onto strongyloides?
How do you treat strongyloides? Is it an anti-helminthic drug?
It is.
Okay. Okay. Fantastic. Yeah.
Yeah.
That was really interesting. That's fascinating about medicine, isn't it? You can go off on so many different tangents. So finally, what I just want to ask is, as 2022 is ending and we are going into 2023, what infections do we need to be aware of in our patients who are presenting to us this year that maybe we're seeing more of than we were a couple of years ago?
I don't think we're seeing more of anything really. I think what we're doing now is our diagnostics are getting better and we're giving names to things. The media,
that's interesting.
Yeah. So what we would have said, oh, that's some form of pneumonia. Now we've got diagnostics at either a molecular or we've got better culturing methods, and we're able to pull out those bacteria or viruses that are actually causing the problems, and then they get a syndrome. That's what happened with COVID. If we weren't looking and we didn't have a diagnostic, that would have never got a name. That would have probably just been some rampant influenza-like disease that's causing pneumonia in people, and the elderly are passing away with this. So I think we just got to be very, very mindful of antibiotic stewardship. I think we've got to be very, very mindful to give antibiotics at the right time, but not to be giving them for things which are non-infectious. We are seeing now, because our diagnostics are getting better, lots more multi-drug resistant organisms, and that's kind of what we're seeing. We're seeing the same bug, just with better armory.
Right. So the actual bacterium itself is stronger, and therefore antibiotics aren't as useful.
So bacteria have different mechanisms. They're actually probably weaker because they're utilizing all that energy to fight us off, to give mechanisms to fight off these antibiotics or break these antibiotics down to save them and preserve themselves. But yeah, so bacteria are the ones that we're going to have to watch out for, especially multiple drug resistant gonococcal infections. So we've got to be thinking about protecting ourselves with regards to STIs, I guess.
Okay.
The other thing is that we're going to be seeing a lot more viruses in the world. We're going to always be getting that next pandemic or that next vaccine preventable bacteria come through the door, because people are traveling more, people are eating into their woods and their forests more, and we're seeing a lot more people who are in really difficult circumstances, having to be seeking asylum and refugee statuses in different countries, who have never had vaccines offered to them.
Yeah, absolutely.
Yeah, sometimes.
So not necessarily new infections, but we're just putting names to the infections that we've probably had for a long time. Obviously, we'll be seeing COVID still. We'll be seeing flu. We're certainly seeing a lot of flu at the moment. And what about scarlet fever?
Invasive group A strep, and so scarlet fever is caused by what everyone in the media is calling group A strep, right? And its species name is Streptococcus pyogenes. Yes, it can cause scarlet fever. If it becomes invasive, then it causes a very, very horrendous sepsis. It can cause necrotizing fasciitis. It's all the same bug, and we are seeing a lot of it. But we've seen, as microbiologists, lots and lots of group A strep over the last couple of years anyway. But we have had a number of invasive types which have caused a lot of problems. So GPs so general practitioners, what we have as family doctors in the United Kingdom, are doing what they can do with regards to sore throats. Most will be viral and they will hold back antibiotics. But yes, there will be cases where that is more of a pleural tonsillitis that we're seeing, and they should have antibiotics because yes, it may be group A strep, Streptococcus pyogenes. So we are going to see, you're going to hear more about it. We're still probably going to see the same amount.
Okay.
Whether or not it's going to go down if the United Kingdom government actually goes ahead with its mass antibiotic distribution plan, I don't know. And I don't know if that's going to actually be a good thing or a bad thing for resistance. We will wait to see.
Yeah, it's certainly scary times, isn't it? And I think you're right, a lot of the last sort of few months, definitely huge amount of media coverage now about infections.
Yeah.
There's not a day that goes by where there isn't an infection on the front page of a newspaper or on the news or on social media.
Yeah.
So we're certainly much more aware, definitely since COVID.
And the pressure on doctors from the public to do something about these things that have been around for a long time is increasing. But I think it's our job here to just make sure that the public are well educated from professionals rather than from the Daily Mirror or the Sun, our UK papers, and make sure that they've got the right information so they can make their judgments as well.
Yeah, absolutely. Thank you so much.
You're very welcome.
Again, some really key important pieces. Again, always so much to take away from these podcasts. So thank you so much for joining me again today. Certainly from today, I'm going to think about bacterial infections. I think it's really interesting what you say about we don't necessarily have more, it's just that we're more aware of them, and our testing is better, actually much better than it was before. And that's, we still have to think about flu, we still have to think about COVID, because they are still there. And also, again, as in the gentleman I saw, he knew there was something wrong, and it's about listening to that patient and following the patient's gut instinct, because he knew there was something not right. Thank you so much for your time. Thank you to everybody for listening, and we will be back soon. Thanks for listening. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.